Decay, Missing, and Filled Teeth Index. The purpose of this index is to determine the status of dental caries activity of decay, missing, and filled teeth or surfaces of permanent or primary dentition. The caries index measures on a rational scale. The measurement protocol is evaluate 28 teeth in the case of permanent dentition or 20 for primary dentition. 5 surfaces are evaluated of posterior teeth and 4 surfaces on anterior teeth. Then the totals are calculated per each indicator: distal, mesial, and facial. Unerupted teeth, congenital missing teeth, supernumerary teeth, or teeth removed for reasons other than dental caries are not counted. When a caries lesion or both caries lesions and a restoration are present, the tooth is recorded as decay. When a tooth has been extracted due to caries, it is recorded as missing. Permanent or temporary filling is present, or when a filling is defective but not decay, is counted as filled. The teeth restored for reasons other than caries are not counted as filled. For scoring, sum the totals within each category, so decay, missing, and filled, and the range for teeth is from 0 to 28, and for surfaces from 0 to 128. The measurement problems of this index is that it could be hard to determine if the caries was the cause of the missing teeth, if the restoration was placed as a aesthetic reason or preventive, or if early lesions that could have remineralized were restored. The limitations could be the observer's bias and variability depends on the researcher's ability, only indicates the number of teeth at risk and estimates treatment need, and give equal weight to decayed teeth and well-restored teeth. This index could be useful too, for example, to determine the effects of fluoridated water and total caries rate in a population. Prevalence, comparison of dental caries at a certain age or dentition.
Today I'm going to be talking about root caries index by CATS, also known as RCI. The purpose of this index is to calculate the severity of root caries and outline root caries prevention in populations that are higher risk. It involves teeth with caries lesions on the roots, root restorations, or teeth with recession. It measures teeth that are at risk of developing root caries. This type of dental index uses ratio as a scale of measurement. Root caries are normally identified by using a dental explorer around the teeth. RCI scoring is normally calculated by counting the number of surfaces with root lesions, dividing it by the number of root surfaces with gingival recession, and then multiplying that number by 100. The higher the score, the more diffuse the caries are. Some of the problems of the RCI are no recession but high-risk caries, the existence of subgingival root caries lesions, surface visibility, and missing teeth. Some of the limitations of this index are age, sex, diversity of the population. This index can only be used on teeth that have gingival recession, root caries, and/or root restorations. And it is hard to identify individuals that are at risk of having root caries. This type of index is useful in epidemiological studies, such as measuring the effects of fluoridated water and the impact that it has on root caries.
The next topic that we're going to talk about are periodontal indices. There are 3 kinds, and the first one is Periodontal Index by Russell, or also known as PI. The purpose of PI is to measure periodontal disease in population based on the clinical exam or combined with radiographic evaluation. We can also say that it records both the reversible and irreversible changes caused by the periodontal disease. It is measured using the ordinal measurement and uses tools like the mouth mirror and regular probe. For its procedure, it performs a clinical examination with periodontal probe and diagnostic radiographs. As for its scoring, each tooth assessed score of 0 to 8 and then average scores to determine index. If calculating for a population, average all individual scores. The higher the score, the higher its incidence of periodontal disease. As for its calculation, the PI score per individual is obtained by adding all of the individual scores and dividing by the number of teeth present once examined. There are some limitations for this index. First, the results tend to underestimate the true level of periodontal disease, especially early bone loss, since only a mouth mirror and no calibrated probe or radiograph is used. Second, the number of periodontal pockets without obvious supragingival calculus is underestimated. Examples of studies that the periodontal indices can be used are epidemiological surveys, like the one in National Health Survey in the USA. Now, Kiana will explain the other two periodontal indices.
Two other periodontal indices are Community Periodontal Index, or CPITN, and Periodontal Screening and Recording, or PSR. Both classify individual or group periodontal treatment needs quickly, efficiently, and at a low cost. CPITN was developed primarily to survey and evaluate periodontal treatment needs rather than determining the past and present periodontal status. It does not record irreversible changes such as recession. PSR was designed to facilitate early detection of periodontal disease with a simplified probing technique and minimum documentation. PSR enhanced the original CPITN coding system with an addition of an asterisk symbol representing areas of furcation involvement, mobility, MGDs, and recession. Both of these indices use an ordinal measurement scale. The measurement tools and protocols include a special dental probe with a ball end and color band ranging from 3.5 to 5 millimeters. This can be metal or plastic. The dentition is then divided into sextants. The clinician only observes the position of the color-coded band on the probe in relation to the gingival margin as either completely visible, partially visible, or not visible. Furcation involvement, mobility, MGDs, and recession are coded by an asterisk. The highest score in each sextant is determined and recorded. The scoring scale ranges from 0 to 4. Code 0 is given when there is no sign of pocket or calculus and bleeding on probing. This is an indication of gingival health. Code 1 is given when there are no pockets, calculus, or overhangs, but in which bleeding occurs on probing in one or more gingival units. This is an indication of mild gingivitis. Code 2 is assigned to a sextant if there are no pockets exceeding 3 millimeters, but in which dental calculus and plaque-retaining factors are seen or recognized in subgingival regions. This is a sign of established gingivitis, and scaling, removal of overhangs, and improvement of oral hygiene is needed. Code 3 is given to a sextant that harbors 4 to 5 millimeter pockets. This code indicates mild periodontitis, and scaling, removal of overhangs, and improvement of oral hygiene is needed. Code 4 is given to a sextant that harbors pockets 6 millimeters deep or deeper. Periodontitis and complex treatment such as surgery is needed. Two measurement problems that might be encountered are the PSR indices may give false results to clients with enlarged gingiva or recession. Differentiating between pseudopockets and periodontal pockets can be more challenging in children. Limitations of both of these indices are they provide partial recordings. They exclude some important signs of past periodontal breakdowns, and scores are not diagnostic since neither system measures clinical attachment levels. The types of studies that these indices may be used for include observational studies such as PSR being tested as a screening tool for periodontal disease, and they have also been used to collect data regarding the relationship between systemic conditions such as diabetes and declining periodontal health.